Good evening, everyone. We're happy to have everyone here. It's good that you've spared some time to be part of this presentation. So we are continuing with the clinical neuroanatomy course series that we've been having for the past 2 months now. So today we are having Dr. Temitayo from Nigeria to present today. So as usual, before we get into the presentation, we're going to introduce ourselves. I'll be calling out names as they appear on my screen. So for now, I'm going to ask Dr. Kabulo to introduce himself.
Hello, everyone. My name is Kabulo, consultant neurosurgeon in Lubumbashi, Democratic Republic of Congo.
Thank you so much, Dr.
to be here today.
We are so happy to have you. Then we have Dr. Chinedu.
Hey, hi, this is Chinedu Egu, currently junior doctor in Queen's Medical Center, United Kingdom. Thank you.
Thank you so much, Doctor. We are happy to have you. Then we have Olalua Ezekiel. Mr. Kanshituruka, can you introduce yourself?
Good evening, everyone. My name is Kanshituruka, medical student from University Zambia and AFAN's candidate to Zambia. Thank you.
Thank you so much, Mr. Kani. Then we have Ebenisha.
Hi everyone, I hope I'm heard. My name is Ebenisha Majata. I'm a fourth year medical student from Copperbelt University, Zambia.
Thank you, Ebenisha. Then we have Dr. Elemezo. I hope I pronounced the name correctly. Dr. Alamezo.
You tried. Good evening. I'm Alamezo Hilary. I'm a fifth year medical student at the University of Ibadan.
Thank you so much. We're happy to have you and welcome. Okay, we have Waxon.
Hello, everyone. This is Waxon Charles Rukere, a third year medical student from the Copperbelt of University, Zambia.
Thank you, Charles. All right, so I think we're going to get into the presentation, and my name is Dawins Chimba. I'm a final year medical student from Copperbelt University School of Medicine in Zambia, and I'm the current president for the Association of East African Neurosurgeons. So like I mentioned earlier, we're continuing with the clinical neuroanatomy course, and today we are happy to have Dr. Temitayo to present. So at this point, I'm going to hand over to Dr. Temitayo to go ahead with the presentation. You can introduce yourself and continue the presentation. Thank you.
Thanks, Darren, for giving me the chance and the opportunity to participate in the clinical neuroanatomy series. I am Dr. Temitayo Ayantayo. I'm a pre-residency fellow, a neurosurgery pre-residency fellow at RNC Neurosciences, a private neuroscience practice in Nigeria. I'm also the Nigerian representative for AFAN. So today I'll be discussing the ventricular system of the brain. So just give me a minute. Okay. Can you hear me?
Yes, we can hear you.
Can you hear me?
Yeah, we can.
Hello?
Yeah, we can hear you.
Okay. Yeah, so I'll be presenting the ventricular system of the brain, and I'll be following this outline as I'm shown on the screen. And then the objectives of this presentation is to understand the ventricular system, to understand relevant pathologies and the clinical and surgical integration of the neuroanatomy. I would put forth a clinical vignette. This patient was seen in our clinic about 2 months ago. It was a 43-year-old man who presented with a history of memory loss, gait apraxia, and urinary incontinence. He had associated history of developmental delay and learning difficulties. He was neurologically intact on examination, except gait instability. He had no fine motor impairment. I want us to bear this clinical being in mind because its importance will be called into play as we progress with the presentation. The ventricles of the brain are a communicating network of cavities filled with CSF, and they are located within the brain parenchyma. They're primarily composed of the two lateral ventricles, the third ventricle, the fourth ventricle, and the connection between the third and the fourth being the cerebral aqueduct. And we can see in this image to the right side of the screen, the coronal plane of the brain. We can see the lateral ventricles, and then we can see the third ventricle and essentially the ventricular system of the brain. And this is another image which depicts a sagittal view of the ventricular system of the brain. The structure marked with the Roman figure 1 is the lateral ventricle, and which is on the left side, and the one marked with Roman figure 2 is the other lateral ventricle. Roman figure 3 is the third ventricle, and the fourth ventricle is highlighted here by Roman figure 4. And we can see the connection between the third and fourth being the aqueduct of Sirius, or the cerebral aqueduct. And then we can also see the foramen of Monro, which is the connection between the lateral ventricle and the third ventricle. And then also depicted on the picture are the different systems that also contribute to some of the outflow of CSF. We can see the cisterna magna, we can see the cisterna pontis here, anterior to the pons. And yeah, so embryologically, the ventricular system is derived from the lumen of the neural tube. And I remember Darwin had a presentation about 2 weeks ago where he kind of talked about how the cerebellum and the embryological derivatives. So the telencephalon gives rise to the lateral ventricles. The diencephalon, the cavity of the diencephalon forms the third ventricle, while the mesencephalon gives rise to the cerebral aqueduct. And you can see this depicted in the image of the secondary brain vesicles on the right side of the screen, and the rhodoencephalon gives rise to the fourth ventricle. The theft of capillaries invaginate the roofs of the prosencephalon and the rhodoencephalon, which forms the choroid plexuses of the ventricles. On the image seen here on the right, excuse me, please. The image seen here on the right, on the left rather, we can see a sagittal view of the brain with the ventricular system highlighted, and we can see the red structures here, the choroid plexus, which basically produce CSF. And the choroid plexus is formed from the vascular invagination of the pia into the ventricles, and they are covered by a layer of ependymal cells, which are continuous with the lining of the ventricles. The CSF is produced by the choroid plexus, like I said earlier, and then this lies within the atrium and the body of the lateral ventricle. If you can see my arrow, which has been highlighted here, and then in the third ventricle, here is the choroid plexus highlighted in red, and then in the roof of the fourth ventricle, which you can see here. So this essentially depicts the choroid plexus at their anatomical location. The arterial supply of the choroid plexus is the anterior choroidal artery, and which is a branch of the internal carotid, and also the posterior choroidal artery, which is a branch of the posterior cerebral artery. And the arterial pulsations in the choroid plexus also help in circulating CSF. CSF is essentially an ultrafiltrate of plasma, and it surrounds the brain and the spinal cord. The total volume of CSF is about 150 mils, with 125 mils of this being in the subarachnoid spaces and 25 in the ventricles. The rate of production is about 20 mils per hour. The functions of CSF include protection, so it helps cushion the brain against the bony skull. And then buoyancy, the effective weight of the brain is about 1,500 grams. And because of the brain being suspended in CSF, this gives it a weight of less than 50 grams. So it helps reduce the effective weight of the brain. And then homeostasis, the CSF contains electrolytes which are necessary for maintaining proper homeostasis. This chart here depicts the flow of CSF, and the ventricles constitute the internal part of the communicating system of the CSF, containing CSF, while the external part is formed by the subarachnoid space and the cisterns. So on the flow chart here, we can see the choroidal plexus, which forms CSF, and then the lateral ventricles, the choroidal plexus and the lateral ventricles, both right and the left, and then the CSF flows through the intraventricular foramen of Monro into the third ventricle, and then through the aqueduct of Sirius or the cerebral aqueducts, whichever name you fancy, and then this goes into the fourth ventricle, and this either goes into the central canal, through the central canal of the spinal cord, or it goes into the subarachnoid space through the foramen of Magendie and the foramen of Luschka. So we have two lateral foramen of Luschka and then the medial foramen of Magendie. So a very simple way to remember this is L lateral Luschka, median Magendie. So, and then we have two lateral foramen of Luschka. And then from the subarachnoid space, it flows into the subarachnoid, into the arachnoid villi at granulations. And from here, it gets drained into the venous sinuses of the brain. The arachnoid villi are small convoluted projections of the subarachnoid space, and they penetrate into the venous sinuses. So if we can see this figure by the right side of the screen, we can see essentially this depicts the flow in a schematic diagram. So the lateral ventricle goes through the intraventricular foramen of Monroe into the third ventricle, into the aqueduct of Sylvius, and then this goes into the fourth ventricle, essentially. I'm sorry, oh boy. And then this goes into the subarachnoid space, and then it kind of just baits the brain. And then from that subarachnoid space, we have arachnoid projections, which interface with the venous sinuses and predominantly the superior sagittal sinus of the brain. So the villi are most numerous in the superior sagittal sinus, and the arachnoid villi function as one-way valves, allowing the passage of CSF into the venous blood. So it's essentially a one-way valve, so there's no reverse flow into the arachnoid villi. This is a closer image which kind of helps depict this better. The CSF and the arachnoid granulation is separated from the venous blood in the dural sinuses by one layer of mesothelial arachnoid cells. So the arachnoid cells interface at this portion, and then we have a layer of vascular endothelium, which is seen at this portion over here. So this is essentially the dural sinus, and here is the mesothelial cells of the arachnoid. So let's go into the body of the ventricular system proper. The lateral ventricles are the largest cavities of the ventricular system, and they are composed of the central portion and three extensions. So if we can see let me move this out of the way. The image to the right of the screen, we can see the sagittal view of the brain. And this depicts here, labeled here, is the anterior portion or the anterior extension or the anterior horn, if you wish, which is also known as the frontal horn. And then here it depicts the body. The body is made up of the central portion, rather, which is made up of the body and the atrium of the lateral ventricle. And here is the posterior horn, also known as the occipital horn. And right here is the temporal horn, same as inferior horn, and then the intraventricular foramen of Monroe is depicted here. The central portion of the ventricles is located within the parietal lobe and is formed by the body and the atrium, like I said earlier. And then the relations, the anatomic relations, are depicted here in this schematic diagram. And the roof is formed by the corpus, the trunk of the corpus callosum, while the medial wall is formed by the septum pellucidum, and the floor of the central portion of the lateral ventricle is formed by the anterior body of the fornix, the caudate nucleus, the thalamus, depicted here, and the striae terminalis. The anterior one is a continuation of the central part into the frontal lobe, and like I said, it's also known as the frontal horn. It's anterior to the intraventricular foramen of Monroe. The anatomic relations are shown here in the image, with the roof being formed by the trunk of the corpus callosum. The floor is formed by the head of the caudate nucleus and the rostrum of the corpus callosum, seen here. The medial wall is formed by the septum pellucidum, and the anterior wall is formed by the genu. Because this is a coronal view, it might be difficult to tell what to show the anterior wall, but it's formed by the genu of the corpus callosum. The posterior horn extends posteriorly into the occipital lobe, and the anatomic relations are shown here, with the roof being formed by the tapetum, which are fibers from the corpus callosum, and the lateral wall is also formed by the tapetum. The medial wall has two elevations. The upper elevation, which is seen here, is formed by the bulb of the posterior horn, which is produced by, the bulb of the posterior horn is produced by the forceps major, which is a derivative of the corpus callosum, while the calca avis, which is from the calcarean sulcus, forms the lower elevation of the medial wall. The inferior horn runs downwards and forwards into the temporal horn, and the relations are seen here with the roof. The roof has both the medial portion and the lateral portion. The medial portion is formed by the striate terminalis, and the lateral portion is formed by the tail of the caudate nucleus. While from the floor, has both medial and lateral portions. The hippocampus forms the medial part, and it's covered by the alveus medially, and then the collateral eminence laterally. So which is seen here, the collateral eminence here, and then the alveus here. The intraventricular foramen is located between the thalamus and the anterior pillar of the fornix at the anterior margin of the body. The two intraventricular foramens of Monro connect the lateral ventricle, which is seen here. So here is the lateral ventricle with the third ventricle. So we can say the third ventricle, here's the intraventricular foramen of Monro. So it essentially connects the lateral to the third. The third ventricle is a narrow vertical cavity of the diencephalon. So this structure in red here is the third ventricle, and the anatomic relations superiorly, we can find the fornix and the corpus callosum, while laterally you have the medial thalamus and the hypothalamus. Anteriorly is the anterior commissure and the lamina terminalis, and you can also find the optic chiasm, and posteriorly is the pineal gland and the abenular commissure. The floor is formed by the infundibulum, and the interthalamic adhesions, which are seen here, are bands of gray matter which cross the cavity of the ventricle, of the third ventricle, and attach to the external wall. So it attaches to the walls of the third ventricle. So we can see it's almost like a structure in the middle of the third ventricle. It has unknown functional significance. The fourth ventricle is diamond-shaped and produces little CSF. The choroid plexus is commonly found in the roof of the which is seen here, commonly found in the roof of the fourth ventricle. And the fourth ventricle is connected to the third by the cerebral aqueduct of Sylvius. And the relationship and the anatomic relations include anteriorly, we can find the pons and the upper medulla. So the fourth ventricle is posterior to the pons and upper medulla, while posteriorly, we can, inferiorly, we can find the cerebellum. And the roof of the fourth ventricle is formed by the superior cerebellar peduncles and the medullary vela. So the clinical applications of hydrocephalus. So of the ventricular system. Hydrocephalus is essentially the most important part in terms of the pathological, the disease that is associated with the ventricular system. So hydrocephalus is essentially an accumulation of CSF within the ventricular system, and we can see the axial MRIs here. This is a T2 weighted MRI axial cut, which shows this is normal and this is abnormal. We can see here the lateral ventricles, we can see the anterior horn, we can see everything just looks slit-like, and the white and the hyperintensity rather represents the CSF, while on the right we can see massively dilated the anterior and the posterior horns of the lateral ventricle. So this is pathological, and this is a T1 weighted image, so NCSF is dark here, but this is an abnormal MRI of a patient with hydrocephalus. So hydrocephalus can be due to overproduction of CSF. So it's a three-way mechanism. So it could be due to overproduction, which is commonly seen in choroid plexus papilloma, or it could be due to obstruction. So solid tumors can obstruct the ventricular system, or it could be due to some form of trauma. It could be idiopathic, or some developmental abnormalities such as the Walker malformation and then Chiari and not Chiari. While reduced absorption is caused by reduced absorption can be caused by subarachnoid hemorrhage, so which kind of forms an adherent film at the level of the subarachnoid space, so such that CSF cannot be absorbed by the arachnoid villi. Meningitis is also notorious for causing hydrocephalus because it forms a film over the subarachnoid space. The non-solid tumors such as leukemia and carcinomatous infiltration. Hydrocephalus could be classified based on the type or the mode of acquisition. So we'll discuss a little bit about the type in the next slide. But acquisition, it could be congenital or acquired. The types of hydrocephalus, the common nomenclature, which is the old nomenclature, is divides hydrocephalus into the non-communicating, which is the obstructive, and the communicating, which is the non-obstructive. So the non-communicating essentially is an obstruction within the ventricular system, and most commonly this occurs at the level of the cerebral aqueduct, which connects the third to the fourth ventricle. And then you have accumulation of CSF within the ventricles. While for communicating, there is no structural obstruction to the flow of CSF. So CSF flows freely within the ventricles, but there's a problem with the absorption, usually around the subarachnoid space, essentially. So, but there's no impairment in flow from the lateral ventricles to the third ventricle to the fourth ventricle. The problem usually is seen typically at the level of absorption. While the current nomenclature classifies all types of hydrocephalus as obstructive, except for the rare type of CSF overproduction. So the current nomenclature just regards almost every form of hydrocephalus as obstructive. But the thing with this is those are the more common forms of hydrocephalus, which are commonly seen. Choroid Plexus papilloma is essentially rare. And this divides hydrocephalus into intraventricular obstructive or extraventricular obstructive. So the intraventricular obstructive is almost similar to the obstructive hydrocephalus in the old nomenclature, which basically is obstruction within the ventricular system, while for the extraventricular is similar to the communicating, which is obstruction outside the ventricles, usually at the level of the arachnoid villi, which could be as a result of previous bleeding, infection, inflammation. This leads to thickening of the arachnoid and decreased absorption of the CSF. These are MRI images which kind of help detect what level or what kind of hydrocephalus you're dealing with. So essentially, in non-communicating hydrocephalus, which is the obstructive type, the obstruction usually occurs proximal to the fourth ventricle, which causes ballooning of the lateral ventricles, which is seen here, the anterior ones and the posterior ones, and also the ballooning of the third ventricle can be seen here. So this points to a form of obstruction before the fourth ventricle. So we can see dilation of all ventricular systems are proximal to the fourth ventricle. While here we can see both ballooning of the lateral and the fourth ventricle. Here's the fourth ventricle. Remember we mentioned the fourth ventricle is diamond shaped. So there's ballooning of the fourth ventricle. So this suggests that the level of obstruction is distal to the fourth ventricle. And this can typically be a form of communicating hydrocephalus. Other variants of hydrocephalus include normal pressure hydrocephalus, which is idiopathic in nature, and it causes increased resistance of CSF absorption across the arachnoid villi. And usually on MRI images, you find them uniformly dilated ventricles, which are not congruent with cortical atrophy. Cortical atrophy sometimes gives some false sense of hydrocephalus, which is known as hydrocephalus ex vacuo. But then in normal pressure hydrocephalus, the degree of cortical atrophy cannot be correlated with the dilation of the ventricles. And there can also be periventricular lucencies, which is transependymal resorption, which is seen on the MRI images. And there's this popular mnemonic, which is both wacky and wobbly, which is commonly seen in patients with normal pressure hydrocephalus, urinary incontinence, gait disorder, and then dementia. So wet, wacky, wobbly. While the other variant is idiopathic intracranial hypertension. This is commonly seen in young obese women, and there are some risk factors that predispose them to these things, like the use of for obese women, 40, the use of vitamin A, excessive use of vitamin A. These are some of the things that are risk factors. Although it's a diagnosis of exclusion, but the ventricular system is normal. There's no dilation of any of the ventricular system. The only thing that will be seen is elevated CSF pressure when you do a CSF tap. So there's elevated CSF pressure, which is why it's called idiopathic intracranial hypertension. The ventricular system is normal, but there's an elevation in the CSF pressure. So the treatment of hydrocephalus essentially could be medical, could be minimally invasive, or in terms of less invasive techniques, depending on what the cause of the hydrocephalus can be. And then most invasive is surgical treatment. So for medical therapy, acetazolamide is commonly given, which is a carbonic anhydrase inhibitor. Carbonic anhydrase is essential in the formation of CSF. So if you give a carbonic anhydrase inhibitor, it reduces the rate of production. And this is commonly used in patients with idiopathic intracranial hypertension. While for patients with hydrocephalus ex vacuo, there's a test called the Miller-Fisher test, which essentially you either do a large volume tap to reduce the volume of the CSF to see if there'll be improvement in the patient's clinical features. So essentially you want to do a neurologic exam and a physiotherapy assessment before you do the tap, and then you either do a large volume tap or you do a 3-day lumbar drainage, and you compare what their assessment is after the tap or the lumbar drainage. So if they've improved neurologically post the lumbar drain, then it's an indication for an insertion of the VP shunt, which might be helpful in the treatment of normal pressure hydrocephalus. While other surgical treatments include third ventriculostomy, that's the third ventricle surgery, and then shunting, which could either be a VP shunt, but we'll talk more about this later on. And then if it's a tumor that is obstructing the flow of CSF, so a surgery can be done to resect the tumor and all of that. And then choroid plexectomy is done to treat choroid plexus papilloma. So essentially the treatment is directed towards the cause of the hydrocephalus or the etiology. So for VP shunt or for endoscopic third ventriculostomy, there are access points to the skull, which could either be anterior or the posterior. So anterior access points includes the Kochars, the Kaufmans, Menofsky's, the Tops points, while the posterior access points are King's, Frazier's, but I will depict some of this with images later on. So the Kochars point is used for endoscopic third ventriculostomy and the external ventricular drainage for CSF diversion. It's usually one to, as depicted in the image here, but it's usually 1 to 2 cm. Here's the coronal suture, which I'm highlighting with my cursor, and it's usually about 1 to 2 centimeters anterior to the coronal suture in the mid-pupillary line. So here's the mid-pupillary line here, this dotted line that you can see here. And then it's 11 cm from the nasion. Here's the nasion, 11 cm from the nasion, and 3 cm to the right of the midline. Typically, when most of these access points, the right side is preferred because it's the non-dominant, typically the non-dominant side. So to prevent any form of injury to the eloquent areas of the brain. And then it's about 6 cm deep from the surface. So that's the Kochars point, and it's used for endoscopic third ventriculostomy and the external ventricular drainage. The King's point is used for VP shunt. It's 2.5 to 3 centimeters superior and posterior to the pinna. So you kind of measure 2.5 cm above the pinna and 2.5 cm posteriorly. And this is used commonly for insertion of the ventriculoperitoneal shunt, and it's about 4.5 centimeters deep. Dandy's point is more posterior, is a posterior access point, and is used to access the posterior horn of the lateral ventricle. It's 3 cm above the inion. Here is the inion, and then it's 2 cm to the right or the left, but commonly the right is used, and it's 5 cm deep. The Frazier's point is used for urgent ventricular bypass and also in posterior fossa surgery, but for the sake of this presentation, we're talking about the ventricular system. So it's 6 cm above the inion and 3 to 4 cm to the right of the midline. And it's about 10 cm deep, and you target this region by aiming at the medial canthus of the eye. Sanchez' point is used for catheterization of the temporal horn of the lateral ventricle, and it's 5 to 6 cm from the inion here and 2.7 cm to the right of the midline. So let's talk about ventricular shunts now. So ventricular shunts basically help in diverting CSF from the ventricles into other areas of the body. And the shunts are named after what kind of the two sites from which you're draining and from which you're draining into. So for instance, you can have a shunt from the ventricles to the peritoneum, which is the ventricular peritoneal shunt, which is the most common shunt. And you can see the image here kind of depicts the ventricular catheter in the lateral ventricle. And then you have the valve, and it goes down, it's tunneled under the skin, and it empties into whatever structure you want to connect it to. So the ventricular atrial shunt is connected to the right atrium of the heart. The ventricular pleural shunt rather is connected to the pleural cavity, but these are less commonly used when compared to the ventricular peritoneal shunt. The ventricular cisternal shunt is connected to the cisterna magna, while to the subgaleal space is the ventricular subgaleal shunt. And then, like I mentioned, the name of the shunt is dependent on the area of drainage and the area you're draining into. So a lumboperitoneal shunt is a shunt from the lumbar region into the peritoneum. So here's an image of a child who has triventricular hydrocephalus as depicted in the sagittal cut of the MRI image shown to the left. And here we can see the mark for the insertion of the shunt in this patient. And the patient whose clinical information I put earlier, the one on the clinical vignette. So here is MRI images, and we can appreciate from the clinical presentation of the patient to the anatomical correlation. So I'll just play a short video which depicts the brain MRI of that patient. So as we can see, massively dilated lateral ventricles. Here's a coronal view highlighted by my cursor, and here on the video, which is moving here, is the axial cut, which kind of shows massive ventriculomegaly. And then we can see extreme dilation of the third ventricle here. So this is this video basically depicts the coronal view of the patient's MRI. And you can see extreme dilation of the lateral ventricles here. And there's some evidence of transepidermal resorption along the borders of the lateral ventricles. And here's a sagittal view. Although this is a T1 image, so CSF is dark, and then we can see transepidermal resorption. You can see the fourth, let me just go back a bit. You can see on this sagittal view, the fourth ventricle here is normal sized. So which points to the fact that the mechanism of hydrocephalus in this patient is proximal to the fourth ventricle, which points to a form of obstructive hydrocephalus. And since we in this patient, an assessment of aqueductal stenosis was made, and this patient is being scheduled for the procedure I'll describe in the next slide, endoscopic third ventriculostomy. Like I mentioned, the right quadrant point is used predominantly for third ventriculostomy, and the scope is navigated through the foramen of Monro, and the premammillary ligament is perforated and dilated, which then helps to create a communication channel between the third ventricle and the chiasmatic, the prepontine systems, and interpedicular systems. So rather than the CSF flowing from the third through the fourth ventricle, through the cerebral aqueduct of Sylvius, because of the aqueductal stenosis at this level, which is highlighted by this arrow, then the endoscope rather is navigated through the perforate and dilate the premammillary membrane somewhere around here, and the CSF then flows through a new channel into the prepontine, the interpeduncular, and the chiasmatic systems. When left untreated, hydrocephalus gives a high risk of cognitive disturbances and physical disturbances and death, which has been the cause of progression in the patient that was depicted in the clinical opinion. So in conclusion, the knowledge of the anatomy of the ventricular system is essential in the management of pathologies of the ventricular system. Here are my references. Thank you very much for listening.
All right, thank you so much. Perhaps we have questions from the rest. You can just either raise up your hands, or you can just, show yourself.
Hello? Are you able to get it?
Yes, we can get you.
Yes, I have a question. I wanted to find out the mechanism of action of acetazolamide. Yeah, in the treatment of hydrocephalus.
Okay, do I take the questions now, or do I wait till the end and address all the questions?
I think you can answer straight.
You can answer it.
Okay, so acetazolamide is a carbonic anhydrase inhibitor, and carbonic anhydrase is an enzyme which is essential in the formation of CSF or the production of CSF. So commonly it's used in the treatment of idiopathic intracranial hypertension. So if you give a carbonic anhydrase inhibitor, which is acetazolamide, essentially you are reducing the production or formation of CSF, which helps with the symptomatology of the patient.
Yeah, I think she got the answer. That's the correct mechanism. Then Dr. Temitayo, what do you do when you are giving acetazolamide to the patient? There's a precaution to take when you are giving that.
One of the things you want to monitor is the blood gases of the patient. So you want to do an ABG because you're worried about the acidosis, which may result from the use of acetazolamide. So you want to check the blood gases, and then if the patient is acidotic, you want to correct that.
Okay, which electrolyte are you worried about?
You're worried about bicarbonate?
More the potassium. When you are giving acetazolamide, always add potassium, because when someone is receiving whatever, acetazolamide is eliminating potassium. So always give potassium when you are giving acetazolamide. Okay, maybe there are no questions. I have a few comments. I have also questions. I'll be going step by step. So there is also one comment. I think I would like him to share the presentation. I will give a comment on one diagram. But the first one, you mentioned like there was a diagram which was showing ventricles, lateral ventricles, then third, then fourth. Why are they calling them lateral ventricles? Why not to say like this is the first, this is the second, then third and fourth? We have only the third and fourth. Why are those called lateral ventricles? Why are we not calling them first and second? I don't know if you came across that.
I didn't come across that while doing the presentation, but I would typically infer that since they are paired means they are paired ventricles, so it's essentially the same ventricle just laterally placed on the right and the left. I mean, that's what I would think, but I'm not sure. I didn't come across that in the course of presentation for this discourse.
Yeah, that was the discussion the moment they were like giving numbers to the ventricles, because imagine they said, okay, let us say the first one is the one on the dominant hemisphere, but all of them don't. All of us, we don't have a dominant hemisphere on the left side. A small percentage have a dominant hemisphere on the right side. So then they said, okay, if we say the first one is the left because that's the dominant, what about someone who is a dominant, the one who is left-handed, dominant hemisphere is on the right? Are you going to say that's the first? You get it? So it was like a discussion. They failed to say, okay, this is the first, this is based on what? That's why they just said, okay, let us call them lateral ventricles. It's because of the hemisphere. They couldn't say, okay, this is the first, this is based on what? Maybe the first answer was, the first question was, can we name them according to the dominant hemisphere? Unfortunately, we do not have the same dominant hemisphere. I don't know if you got that.
Yeah, I understand. Thank you.
The second comment, you said CSF, we have 150 mils of CSF, 125 in the subarachnoid space and 25 within the ventricles. How can you divide them according to intracranial and spinal CSF? How much? Because right now we have 150 mils.
Yeah.
And how much is in the brain or in the cranium, and how much is in the spinal cord?
So while presenting, what I came across was that we have about 25 mils in the ventricles, which is 25% rather. We have about 25% of the total CSF present in the ventricular system. So I would assume that it's other 75% would flow in the subarachnoid space, but I'm not sure what exact numbers for the cranial and for the spinal.
Yeah, it's 50%, 50%. It means okay. 75 in the cranium, 75 in the the spine.
Okay.
So yeah, and the rate of production, of course, 20 mils per hour. Usually they say 0.33 to 0.35 per minute. Better to say per minute.
Okay.
And okay, there's a diagram you showed. I think it's better to go back to that diagram where you were talking about arachnoid villi. If you don't mind, you can share again your presentation. Yes, thank you. This is a diagram, but if you can see, CSF is going down from lateral ventricles to third, fourth, then from there, stena magna, and going up. So it's not only one way, it's also going up from anterior, because this diagram is, okay, let me say it's a wrong diagram, because it is like showing CSF is going from posterior, then from the arachnoid villi, it is coming now from anterior going to the spine. Or it is known that from the fourth ventricle, part of the CSF will go through the central canal to the spine, and part of it will go to the subarachnoid space in the spine. So these arrows, which are in front, like from the parietal, frontal to the temporal, going down, they are not correct. They're supposed to go, all of them, going up, even from anterior and from posterior. So the diagram wasn't well illustrated. Okay. Then another comment was, okay, you said hydrocephalus, it's accumulation of CSF within the ventricular system. It's within the ventricular system and or the subarachnoid space. We have to add that because when you get communicating hydrocephalus, there is also excess fluid into the subarachnoid space. There is also a type, a variant of hydrocephalus called external hydrocephalus, which is found in children less than 1 year, where you get the ventricles are normal, but there's more CSF in the subarachnoid space. So that is called external hydrocephalus. So the definition, we have to add and or in the subarachnoid space. Voilà. Now to finish, a small question. You mentioned ex vacuo hydrocephalus. What's the mechanism and when do we find that hydrocephalus?
Hydrocephalus ex vacuo is commonly seen in cerebral atrophy. So it can be seen in degenerative conditions which will cause global cerebral atrophy.
Yes. Mostly in elderly also.
Yeah, in
when
elderly.
when someone is getting old, the brain is shrinking, so you get brain atrophy. And according to Morrow and Kelly doctrine, the CSF will fill up that space where the brain was. And also, if you find it in young, usually is from those who take too much alcohol, because alcohol can also cause brain atrophy. Then you get also that type of hydrocephalus. Otherwise, it was a very good presentation, Dr. Temitayo. Well done, and congratulations. Keep it up. I enjoyed your presentation, and yeah, especially when you're talking about the relations of the ventricles, that was excellent. Congratulations.
Thank you very much.
Thank you so much, Dr. Kabulo, for that comprehensive addition. And thank you so much, Temitayo, for that wonderful presentation. I guess we don't have further questions, so we will come to the end of the meeting. And thank you so much once again to everyone that managed to attend the meeting.